So, my name is Joel, and I am working with UnitedHealthcare, basically as a care advocate. So, help out with more of actually members, as we were talking earlier, but members and what they need, on the home side. And are they having resources? Are they needing any information and support to hopefully keep them, one, from going back to the hospital, and second, moreover, just to make sure they're doing okay. One of the things that I really enjoyed would be the precepting. And so, because that's kind of a neat, people don't think about that part. But for this job, it's more so what is that person having challenges with? Are they needing help with medication? Are they needing help with getting the doctor, getting a therapist? Do they have the ride to get to the doctor? Do they maybe there's a caregiver situation. Is there a caregiver that is a little bit more stressed because maybe they're dealing with dementia, and so there are all sorts of, or do you have somebody, roles I've done in the past would be for hospice. Do the family members understand how to help their loved one, what number to call? And the insurance side, that's a big part, is having that phone number that if they are having challenges, what number do I call?
Like,
That and that's the hard part, is the home, with the home hospice, because with the home hospice, it's the caregiver that's doing all of the parts, and I've done inpatient hospice and home hospice. My toughest hard part was my uncle. So my uncle was on hospice, and it was a hard situation because I'm flying up to Pennsylvania, and he had end-stage renal disease. He knew he was dying, and I walk in the room. My cousin, she was one of those that she thinks that she knows the medical, even though she hasn't been trained. And here he is, he's having that shortness of breath. He's having that anxiety. And the first thing I'm looking at is he needs some morphine to help him with his breathing. And I'm talking to him, hey, look, would you like something to help you with your breathing? And he was just like, yes. And then my aunt was sleeping, and I told my cousin, hey, look, this can help him out. And she's like, well, we need to reach out to my aunt. And just like, okay. And so the interesting part was that hospice company is connected to the insurance side of medicine. And I remember that I would have a call to the hospice nurse to say, these are the meds that I'm giving. It's not working. He needs to have some of his medicines up. And so at any rate, we had the medication increased. What was interesting was my uncle, he said, I know that you love me. He said, I know that you would do nothing to hurt me. He said, make me comfortable. And basically worked with every other hour having to give more medicine. The hard part for the family and the caregiver is really, it's a difficult part because, like you said, they're scared. If I give this, it's going to kill my loved one. In hospice, we always start lower dose. You don't overdo it. If you're having symptoms, manage those symptoms. If the symptoms aren't being controlled at the home side, you call the hospice agency. They tell you what to do. They can have a triage nurse come out If that's still not working out, then you go more of a hospice home for general inpatient, which I worked very many years on. Uh, but the beautiful part was that he did pass the next morning and he was comfortable. And my aunts were just kind of uh, in shock about how would we have done this if I wasn't there. And it's a thing that I take for granted, you know, but for the families or the grandkids, you know, it's what are those symptoms? And the first thing is, are you comfortable? It was a bit of a boomerang. Uh, when I was in high school, I wanted to go environmental because at the time, environmental science was the thing. Uh, I had volunteered at a nursing home. Funniest part was activities. And so here I am with geriatrics, some people with Alzheimer's playing Uno, and sometimes the game would have to change depending on uh, the rules would change depending on who you're playing the cards with. Funniest part was that I would be nonchalant, like, okay, now everybody can do a draw two or whatever. Uh, the interesting part was at that time, the director at the nursing home wanted to hire me part time as a high school student. I thought, no, 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 I want to go more environmental. So I did environmental science, uh, healing the soil, and you'll see where this goes in a minute. 2009 corporate downsizing, I was let go. And then I had to do an inner, what do I want to do? And so I thought, I want to be a nurse. And so it's like I kind of boomerang back to that. Went to school, and then it was a neat transition to go from a medium of healing soil to healing people. And the funniest part was I'd have my new patients on a med-surg unit say, well, what's better? The soil that can't talk, the people that can talk? And I said, well, you'll have to ask me that in 5 years. Well, when I started doing hospice, I had both. I had some, patients that could talk and some that couldn't. So I had best of both worlds. Well, the start of the hospice started when I was on med-surg on a comfort floor unit, and I had always thought hospice was something I was interested in. So the med-surg comfort care, we would have oncology, we'd have patients that were dying in the hospital. So my one of my first patients, was COPD, and then later on, I had worked with my other nurses on comfort care patients, and that to me was wow. How can I help the patient and the family? So at that point, I said, I've done at that point about 8 months med-surg, and maybe I want to work some hospice. And so had a friend in Wilmington that had worked for Lower Cape Fear Hospice was the name at the time in Wilmington, North Carolina, and said, I know who you can talk to. So I had an interview. This is inpatient hospice, got hired. The interesting part was that I was then my boss at the hospital said, please don't leave. Said, why don't you stay, PRN part-time, basically one shift every other week. And then the other boss in the hospice home said, hey, yeah. The interesting part with that journey was I thought, I know a whole lot about hospice. I've worked on this med-surg unit with comfort cares, I get it. Boy, I had no clue what hospice was. I started to be like a new baby learning new skills. And so it was really amazing starting to learn that compassion, that how to deal with the families, how to use old school nursing. Don't look at what the blood pressure is, look at the visuals, look at how they're sounding, the colors, and all different aspects that you just don't do in the hospital. The wildest part was then I would go to the hospital, and anytime they would have a comfort care, they would try to give me the comfort care. And then if I had another nurse I was working with that had a comfort care, they'd say, well, can you tell us how much longer this loved one is? I would go in the room. I would actually teach both the family and then the nurse outside the room, say, look for this, this, and this. And so it was kind of a neat journey, you know. And then going from that, I have always wanted to learn something new. And so inpatient hospice, hospital hospice is very different from the home side of hospice. So that's where I came to Duke. And so then I learned the other side of the coin. But it's been an interesting journey going from the hospital to med-surg to comfort care to hospice, inpatient to the home side. And it's been a really fun journey in that part of my career. I know exactly what you're saying. And I do believe that sometimes in any careers, you don't know what door will lead to next. And I'll give you some examples. So I went from, the med surge to hospice inpatient to the home side, and then back to inpatient hospice. COVID hit, and it was just cray cray. And so understaffed, overworked, and saying, this is just a burnout stage. And so life happens the way it's meant to. So then, long story short, is that I ended up joining on the insurance side locally, and then learning as a nurse care manager, helping non-hospice. At that time, hospice kind of burns you out, because you're doing all of the mental. It is a gratitude and an honor to be part of that family and that, for that patient. But it does burn you out. So then I went to nurse case manager role, and then dealing with members, we'll call members now instead of patients, that have up to 5 comorbidities: CHF, COPD, diabetes, a combination of the two, in and out of the hospital. So that started teaching me how to use my ears and assessing what are the members needing at home, starting to work from the home side, getting away from the bedside care. Then from there, started to step up to a lead position, training, being a preceptor, having at one time 7 preceptees to train in 2 weeks. And how do you do that? Going from that part to back, life works out where went back to the hospital as a discharge planner. And then from there, I said, this isn't for me. It was great to learn that. To my old boss, was saying, hey, come on back to the company. So then she was working in mental health. So then I say, okay, now I'll pivot to mental health in the insurance side. learning that part, seeing how can help people out that are in depression or suicidal. How can I help with the resources in that part? And that was a neat experience to a week ago, now doing insurance side Medicaid. So now I'm getting a little bit away from behavioral health to Medicaid discharge planning. So I'm working with the hospital and discharge planning. How are they doing? Is it a safe discharge? What resources is that member needing? Now, if that member has got behavioral health, I know how to deal with that. If they have needing more of a serious illness conversation, okay, can talk about that, you know, to kind of morphing a little bit. So, yes, a nurse's journey, I think you just sometimes don't know what door is going to close and what door is going to open. Right. And you're right, because the behavioral health and hospice are almost so much alike for the emotional stress on the nurse or the social worker, uh, to try to go from, like you just said, the reactive to the proactive. Uh, can I or a case manager from the insurance side uh, collaborate with the member, with the primary doctor, with the resources to make them succeed? And to me, that's a little less stress than the hospice, because at that point, I'm dealing with death day in and day out. Having 20 caseload, and maybe every 2 months it's 20 new, it's revolving. So uh, to me, being with the living when I started the telephonic side is it's rewarding. There are challenges, and that's where a telephonic nurse versus the in-person nurse is night and day. Uh, the telephonic nurse, you have to be good with technology. So you have to be able to adapt multidiscipline. Can I look at Epic? Can I look at different databases? So it's more technology driven. The hospice has been great because in the end of the day, I have to be able to build that rapport from talking to that member or family member uh, quickly. And that you're either going to have that warmth or that empathy. And I've had cases where I'll be on the phone, and then in the case management, it's a lot of a building block, just like when I was in hospice. So it's kind of, can you be able to show that you're there for them? And that, I think the hospice really has molded me to be great on the phone. Uh, because if I didn't have the hospice experience, I might just be, okay, this is this question, this is this question, this is this intermittent of health. But it's a dance. I have to be able to say, tell me about what happened in the hospital, what worked, what didn't work. I've had, and sometimes when I'm calling a member several times, it's a stepping stone. I had one case where a person reminded so much of a hospice patient that I would starting having the serious illness conversation and start talking about palliative. Uh, and then say, have you heard of palliative? No, I haven't. What are your goals? From there, then have you heard of hospice? And then as the phone, you have to feel that conversation out. If I'm listening and if I'm getting a door shut in my face, then I know, okay, we're going to pivot the conversation to something else and then go from there. So it's really, it's just having a conversation. I remember one particular case that I loved because it was a local person nearby. The family member had dementia. And it was a caregiver. The and then I talked about hospice, and the caregiver said, "Oh no, 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 we will not do hospice." And then I was like, okay. And then one or two, like a month later, then the caregiver said they had a loved one that went too quickly on hospice, died, had a bad. And then I said, huh, well, what symptoms are you having? Well, we're having troubles with the agitation and the anxiety. Well, palliative can kind of help with some of those symptom managements. And then this was actually when I was leaving before going to the hospital. And I remember this case because I had talked with the caregiver about more of palliative, which is the other side before hospice a lot of times. Finally, the caregiver said, okay, let's give palliative a try. So start up with palliative, get the medications, and that family member, I remember she said, why didn't I do this sooner? It's like you got to meet the person where they're at. You can't force the conversation. The biggest reward is knowing that you made a difference. That's what it boils down to. Knowing that here's a situation where maybe I prevented somebody from going back to the hospital. Having that voice of I care. I've had so many times that, getting to know that family member or the member themselves or the family member saying, how are you doing? Or had one member that I had recently said she called me her ray of sunshine. Every time I would call her, she's like, Joel, you're my ray of sunshine. And I'm just like, okay. But it's that making that difference that makes you want yes, you're going to have those challenging cases. Yes, you're going to have that honorary person that you're going to say, okay, bless their heart, but you're going to have also for every challenging call, you're going to have so many people you're helping. And so that's the biggest reward. It's the sky's the limit, nursing, I don't know what doors are going to open in 2 years, 3 years. The insurance, sometimes you're on contract. So sometimes one contract ends and then you're learning a new skill. I like where I'm at right now. But it is a neat feeling of, I love teaching. I've precepted on multiple roles. And so I don't know, maybe I'll continue with the members. Maybe I'll go into teaching. Well, I've got my bachelor's, but I don't know I've gone on, but I just don't know the future. But, it's kind of a neat part of you just live today.
Yeah.
Well, I think the hardest thing is that sometimes the one thing I love working from home is that if you're really stressed out, you could have a squeeze ball and be talking. If I'm bedside, you're going to see my facial expression. Well, I'm at an interesting part right now where my parents last year were both inpatient in Pennsylvania, moved them down here to be closer. And so at some point, I see that I'll be still working from home, but probably living with them. And then I'll be more the caregiver. But that's the nice part is that doing the 8 to 5, you go to the hospital, I couldn't do that. And so hardest thing with hospice is just that deer in headlights. I remember one of my patients that I really liked, he was like, I'm so afraid to take the liquid morphine. It's gonna it's going to zonk me out. I said, you know what? Just take a half dose. Just take 4 drops. I said, I'll stay here, in 40 minutes. Stay there. And then he's like, wow, I'm not sleeping. I can breathe. This is the best thing ever. That's where you take that fear away. And so it is that a neat, rewarding aspect is being able to take that fear. So many times you have that patient or that family member that are, oh my God, I can't do this, to we'll work together. And that is just precious. Oh, I think nurses, we could have stories all day long. We don't have that.